morning. I have nothing to disclose, and I'd like to thank Haresh and Jay for the invitation to return to Hot Topics in Neonatology, to Richard for the introduction, and Alan Job for selecting the topic for my talk today. That is a little challenge. So I would like to begin by asking, inflammation, what is it? And inflammation is an adaptive response to restore hemostasis. Now, inflammation can be physiologic or pathologic. And let me give you an example of physiologic inflammation, which is essential for reproductive success. The three processes that are essential for reproduction are ovulation, implantation, and parturition. These three processes are inflammatory processes. There are no bacteria. There is no an abnormal problem. It's just that the body uses the inflammatory mechanism to rupture an ovarian follicle, to implant the blastocyst, or to initiate labor. Now, we are accustomed to thinking about inflammation in pathologic terms, and the two causes are infection, and then there is increasing recognition there are non-infection related etiologic causes of inflammation that we refer to as sterile inflammation, when there are no bacteria, no viruses, or protozoa. So here is an example of a septic arthritis. It's a 25-year-old individual with painful swollen knee, has a positive culture of the joint of the synovial fluid for Staphylococcus, and this can happen any place. In contrast, we have this picture is gout with inflammation of that big toe joint, and that inflammatory process is caused by needles that you can see in this slide in blue and white of urate crystals that induce influx of neutrophils. So this will be a typical example of sterile inflammation. So let's look at inflammation in the perinatal period. Here we have a 26-year-old woman who presented cramping at 25 weeks of gestation. She was cramping for 2 days, increased vaginal discharge. She had an intrauterine contraceptive device in place since 2010. The vital signs show no evidence of fever. The cervix is dilated 2 centimeters, and this is the ultrasound. And you can see in the ultrasound this material that is next to the amniotic fluid. This is the fetal head on the left, and that is sludge. Sludge is often the accumulation of white blood cells and bacteria that are free-floating in amniotic fluid. With that image, we examine the fetus. On the left is a normal stomach, and you can see on the right that this fetus has something inside the stomach, debris. We do not continue to do the ultrasound, and it's quite clear that the patient has gotten pregnant with an IUD in the uterine cavity. You can see the T of the IUD there. We do an amniocentesis. This is how a control amniocentesis will look at 25 weeks. This is our patient, and in the gram stain of amniotic fluid, there are these images. You can shout if you think you know what they are. The patient has progressive cervical dilatation. She has bulging membranes, ruptures the membranes. There is meconium stained amniotic fluid, and we have a spontaneous vaginal delivery of a baby that is 1,000 grams or so. This is the placenta, and this is the IUD that comes right after the placenta. When looking at the umbilical cord, you see these little images over here that represent an abnormal finding in the umbilical cord. They're microabscesses. I'm going to show you histologically how they look like, and this is the baby. So the diagnosis, I think clearly the umbilical cord with microabscesses on the surface, microabscesses in the umbilical cord. This is a gram stain, and the organisms did not look so tiny, so they are fungi. And here is Grocott staining, looking for, and these are candida that are there. The amniotic fluid, this is DAPI. You can see the hypha in red. And this amniotic fluid culture came back positive for Candida albicans. There were no other microorganisms. And I want to remind you that a number of women get pregnant with IUDs, and there is an excess rate of Candida species. So this is an example of an intraamniotic infection that resulted in vertical transmission of Candida, and the baby was treated and everything was fine. Now, can intraamniotic inflammation be treated with antibiotics? This is an important question. The traditional view that I had is the answer is no, but I have changed my mind, and I'll be glad to discuss that in the question and answer period. What about sterile inflammation, which is the subject of my talk? So here we have gout. Can you have the equivalent of gout in the amniotic cavity, and how would that come about? So is there such a thing as sterile intraamniotic inflammation? Obviously, Alan believes that there must be one, and so do I. So we have this circumstance on your left side here, where there is inflammation, the amniotic cavity is in red, and you can see bacteria, where I just show you with Candida. What about this circumstance in which there are white blood cells or there are elevated cytokines, but there are no bacteria with culture or molecular methods? So that is what we define as sterile inflammation. And many years ago, 25 years ago, when doing amniocentesis in patients with premature labor to look for infection, we found that some patients had inflammation in the amniotic cavity. They had detectable IL-1 beta, but they had negative cultures. So I thought that the problem was that the cultures were giving us false negative results. But now, with the advent of 16 RNA amplification and sequencing, and actually using deep sequencing, we found that this is true, that there are some women who have intraamniotic inflammation, but they have no bacteria and no viruses. So this is actually not uncommon. It's more frequent to have sterile intraamniotic inflammation in patients with premature labor and intact membranes than intraamniotic infection. This was a surprise to me. In premature rupture membranes, the opposite is the case. There are more intraamniotic infections than sterile inflammations. But even in patients with a sonographic short cervix, sterile inflammation is more frequent than intraamniotic infection. Now, what are the characteristics of a sterile intraamniotic inflammation? The first point is white blood cells are elevated but modest in comparison with the second column. And I'm asking you to look over here. I don't have a mouse. But the bottom line is that glucose concentrations in amniotic fluid, white blood cell count, and inflammatory cytokines are a lower level. Now, importantly, is the square, the red square. These patients tend to have lesions of acute chorioamnionitis or inflammation in the placenta, and they tend to have phoenicitis. So if you look at the placentas of patients who deliver preterm, approximately 60% have acute inflammatory lesions of the placenta, and they come in two types. Infiltration of neutrophils in the membranes, and this is a maternal inflammatory response, and the mechanism for this is that you have intraamniotic inflammation with bacteria, without bacteria, and then they have a chemokinatic gradient that brings neutrophils into the membranes. And that is the reason why there is acute chorioamnionitis. But this is a maternal host response. When we look at the cytokine networking in sterile inflammation, there is an excess of chemokines in the amniotic fluid in patients who have no bacteria. So there is a chemokinatic gradient. So if you have chemokines around the umbilical cord, you can have this process in which neutrophils invade the wall of the vein and then the wall of the artery, and that will be phoenicitis. And here is phoenicitis. And these conditions, both acute chorioamnionitis and phoenicitis, can be present in the absence of proven infection of the amniotic fluid or the feces.